Now, the indication, the typical indication of looking plate. Just before starting, I show you this fracture. What would you be your choice? Conventional or locking plate? Who would use conventional plate? Locking. Okay, and we can discuss why. Yeah. Now this. Sure, we agree all locking. Why? Comminuted fracture. No bond patches, short metaphysical fragment. Yeah. So looking plate is excellent in this case. But why fail? So this is a simple fracture, but there is a failure. Yeah. Look plate fail, and conventional plate fail. Too much screw fail, and little screw may fail. Why? So this is the answer would be our learning objective. Now we have to identify the indications and the appropriate use and benefits of loop plating, and you see the advantage of loop plating in a special clinical situations, and also very important to outline areas where locking plating may fail, yeah, or may be used incorrectly, and this will lead to failure. Now, why loop plating? It's an issue of biomechanics. So loop plate does not need to be compressed on the bone, yeah? So imagine like that, if you have reduced the fracture well, and you would put a plate and fix it. If you do conventional plating, the plate will pull the bone to the plate, and this you will lose your reduction, or it will be imperfect, yeah? While this would not happen with locking plate, because it's like an internal fixation. Again, it does not need to be compressed on the bone, and this is of very important biological advantage because it will not disturb the perfusion to the bone. Look here with conventional leaders, and I think this is basic. We have discussed maybe in the basic courses, and here in the lock plate doesn't need to be compressed on the bone, so it preserves the biology. Now, screws are unlikely to be loosened. And this is important because it's engaged to the plate. What's the importance of that? In the conventional plate, if you have one or two screws loosened within the plate fixation construct, this will lead maybe to failure of all the fixation and movement at the fracture site and failure, non-unit. While this will not happen in the looking plate, because in the looking plate it will act all the plate as a unit. Now, locking plate screw, they have been demonstrated that it is a more stable, stronger fixation construct, like it's plate bone construct. And this, because it's act as one unit. So, why fail? Look, if it fails, it will bolt at the same time. Not by only losing of one screw, but it also can fail. Why? If we don't follow the principles. Look here, on the other hand, if any screw fails, all the construct will be failed, but not the construct, all the construct will be pulled out. So the strength to be pulled out from bone is much better in the locking plate. And this is because of all these biomechanical advantages. This is indicated when we have problem in the bone quality or quantity. Quality like osteoporotic bone or osteopenic weak bone, and the quantity like when you have short metaphyseal fragment or if there is comminution, and also when you don't have good bone stock like periprosthetic fracture. And remember this. This is the idea. Now we have other indications for looking plate when you have unprotected weight bearing, non-compliant patient. Even if you can do conventional, it's better to have locking plate. Again, in osteotomies, we do all of our osteotomy with lock plate, and we allow full weight bearing early, and also a Nebo technique, as Dr. Arnold told you in his presentation, because in percutaneous fixation, you don't need to, you don't have the chance to compress the plate on the bone. So you cannot do with conventional plating. Okay, look, plating is a good choice. Yeah, you agree? So why it fails? All these looking plate. Why? In most of the cases, the reason for failure is self, because they don't follow the biomechanical principles, the fixation, the advanced and basic principles of fracture fixation. So again, I think Dr. Fuad told you about the absolute and relative stability. You have to ask yourself, do I need primary bond healing? Because our aim always to have, if we can preserve the biology and have anatomic reduction, it's perfect. So if you have anatomic reduction, you should have what? Absolute stability, because this healing is primary. And if you do a functional reduction, if you have a gap, so you should have controlled motion at the fracture, so relative stability. لكن مش مطلق. We should have adjusted or proportional relative stability. Okay, stability. Now you remember this. The motion at the fracture site, the degree of more micro motion at the fracture site will cause deformity of the healing cells, strain on the tissue. And if it is less than 2%, this may lead to primary bond healing. If it's excessive, more than 10, this will lead to destruction of the healing cells. And for relative stability, it should be within 2 to 10%. So you have to be careful when you do fixation using the relative stability principles that the motion should be controlled. Otherwise, you may have disruption of the healing cells. So this is the clinical relevance. When you have simple fracture, please compress and absolute stability, and you expect primary bond healing. If you have simple fracture with very small gap, if you apply relative stability, you will have movement at the fracture site and strain on the tissue and poor healing. But when you have large gap, you need this relative stability, because this motion will enhance hairless formation. Now, how we optimize our fixation? How? Because this is what you are doing in the operation theater. So there are many factors affect the strength and the stability at the fracture site and the strength and stability of the whole construct. And this is sometimes confusing. The position of the screw, I think this is the most important part when you decide do you have absolute or relative stability. Why? Look, this is a question for the seniors. What happened? This is a fixation, looks good, yeah? What happened if you put screw here? You answer this, yes? The position of the screw will affect the working length. And the working length is the distance from the screws at each side, the closest one, at each side of the fracture. So, and this will determine the stability at the fracture side. So when you increase the working length of the blade, this will cause the fixation more flexible, more motion, and the load will be distributed on longer segment of the blade. But if you have a gap and you make it stiff, like closer, the screws closer to each other, there will be more rigid fixation, the working length of the blade is closer, and the stress would be concentrated on very short segment. What does this mean? If you have a gap and no compression at the bone, all the movement would be concentrated in the blade, and this may lead to failure. Look here, you should, if you have a gap, please avoid short middle segment. And now, like this, if you have, you can test it. If you make load on small segment, you can bend it. And if on large segment, it's more flexible. And now you can answer why this failed. Yeah? Because it's rigid, stiff construct on a comminuted fracture, no bone compression, and all the stress is distributed in a short segment of the blade, and this leads to failure. And here, what happened? Stable fixation. Is it stable fixation? So here, it's a simple fracture fixed with the principles of relative stability, and it was well reduced, so the excessive motion lead to destruction of the healing tissue. So you know now why failure happens. So keep in mind when you do plating, if you have simple fracture reduced, you have to have absolute stability, and for functional reduction, multi-fragmentary, you need relative stability. So what happens if we put screw here? Look, working length decrease, small stiff, and if delayed union happen, there will be more load on the plate, and this will lead to failure. Now, if you have no gap, so you need absolute stability, like an articular fracture and simple diaphyseal or metaphyseal fracture. And if you have a gap, multi-fragmentary, if you cannot achieve compression, so you have to obtain or to have a relative stability. So this is maybe in like Dr. Arnold told you, sometimes with minimal invasive technique, you cannot do compression at the fracture site, and this may lead to delayed healing if you do relative stability. So we have to be careful. Now, other factors, the number of the screws and the plate length. And look, the number of screws is very important. In the upper limb, we have torsional forces. So you have to have 3 or 4 screws on each side. While in the lower limb, the problem is axial, so 2 or 3 screws on each side is enough. What happened with the plate of the length of the plate? So you have to think of that, because when you have large gap, you have to use longer plate. Why? And longer plate does not mean that we have to fill all the screws. Take care. Why? Look, what's this? Seesaw. So if you have this thick man, the thin man will go up here, and if you want them to balance, you have to take him away. So the lever arm is more, yeah? And this will be balanced. What happened in fracture? Look, here's the bending force, like the thick man, and here's the fulcrum for rotation, and here the screw will be pulled out. So if you have to achieve good stability of this screw, not to be pulled out, just make it away from the fracture site. Is it clear? Clear? Yes. Seesaw. So make it away. This will prevent pull out of the screw. Now, what's wrong here? The surgeon used long blade, but he didn't use it. Like this. He had extra length, but he didn't use it. Yeah? So the point is not the length of the blade itself, the position of the far screw from the fracture. Okay? Is it clear? Now, this is the general principles for multi-fragmentary screw fracture. Use longer plate, reduce the working length. So you put it closer to the fracture when you have large gap. Don't make it more longer. And the first screw is inserted here. So look, this is comminuted fracture. The working length is too much, and this leads to failure. So this is against principle. So here, long blade, good. Why fail? Osteoporotic bone, the surgeon used monocortical screws. So this is important because in weak bone, osteoporotic bone, the working length of the screw is short, not like in the diaphyseal bone. So whenever you have weak bone, or in terms of strength, osteoporotic bone, or short segment, or metaphyseal bone, please put a bicortical screws, not unicortical screws. And if you end out, always use bicortical screws. Okay, now look at this. We'll reduce, very nice job. What's wrong? Monocortical screws and osteoporotic bone, and this fail. Yeah? So this is a nice technique. If you have a weak bone, that putting the screw divergent, so the pull out strength will be more. Yeah? And look here, this is comminuted fracture and a lady over 80, and you see here long plate, bicortical, some divergence, and this lead to success, healing. So take home message, look plate provides stronger fixation, construct, and more stable construct. And locking plate are indicated in osteoporotic bone and in deficient bone stock, and also in Weaver technique. The biomechanical principles of absolute and relative stability should be followed to avoid failure. Anatomically reduced fracture should have absolute stability. The degree of relative stability should be adjusted according to the size of the gap. So I discussed with Dr. Fadi that we have to introduce like a concept of proportional relative stability or adjusted, and he told me absolute and relative, yes. In the middle, yeah. And also use longer blades. Doesn't mean you have to fill all the screws, and you know why longer blade. And avoid monocortical screws in weak parts.